Age-related macular degeneration, or AMD for short, is a leading cause of significant visual acuity loss in people over aged 50 in developed countries. So we're pleased and delighted to have Dr. McRoberts speak on the causes, treatment, and prognosis of AMD. He will also speak on adult onset glaucoma, sometimes labeled as a silent blinding disease. So Dr. McRoberts completed his optometry studies at the University of Waterloo in 1974 and is part of a private practice in Squamish and West Vancouver. He was the past president of the British Columbia Association of Optometrists, past member of the Board of Examiners in Optometry, and also served as the registrar of the College of Optometrists. He has published and lectured and is a member of several professional organizations. We are indeed pleased to have Dr. McRoberts with this presentation.
Glad to be back. It was very kind of Robert to give me another invite. Always pleased to do this. I just want to let you know that we come in all shapes and sizes. I don't know if I'm the best looking one there, but so today we're going to talk about STDs. I guess that's a bit of a surprise to you, but it means something a little bit different to eye doctors. So what that is for us is sight-threatening diseases. And as Robert mentioned, we're going to talk about two of these, primary open-angle glaucoma and macular degeneration. So we're going to spend a little time on each one and just sort of explain what they are. So we're going to talk about glaucoma first. This is the official definition of glaucoma. It's a primary open-angle glaucoma is a chronic optic neuropathy that causes progressive loss of retinal ganglion cells in their axons. Well, we didn't think that meant very much. This is more of our office one. So it's a group of eye conditions that cause damage to the optic nerve, gradual death of the optic nerve fibers. This causes permanent, irreversible vision loss. Once you have any damage to a central nervous fiber, no matter where it is, at present, you can't get that back. So where are these fibers? This is the outside of the eye we're looking through. There's the very back. That's the optic nerve right there. So if we're looking straight into the eye, that's the optic nerve. And out of that comes a whole bunch of blood vessels and thousands of little fibers spread around. The most sensitive area in the back of the retina is right there. That's called the macula, and we're going to be talking about that a little later. But since we got the slide up, that's where everything kind of interrelates, and they do. But we're going to get more into the macula a little bit later. Right now, we're going to concentrate on the optic nerve itself. So glaucoma usually always happens in both eyes, unless it's from a secondary injury or something like that, although one eye may be way ahead of the other one as far as development. So how does this happen? And why do these cells die? They just take it upon themselves to up and die. So is it a lack of blood flow to the cells? Is it mechanical damage at the optic nerve head? Or, as what most people think now, it's probably a combination of both, and also this new area of the cerebral spinal fluid pressure is also starting to come into the mix as to why glaucoma causes this damage. So these are the big three risk factors. Intraocular pressure. So when I first graduated, intraocular pressure was everything. If you had high pressure, you had glaucoma. If you had low pressure, you didn't have glaucoma. And that turned out to be completely wrong. You can have normal intraocular pressure and still have glaucoma. So intraocular pressure, the pressure inside your eye, is only a risk factor. Funny looking optic nerves, and we're going to look at some of those. And also it came out in a big study in about 2004 when they were predicting who was going to get glaucoma, and they looked at all these factors, central cornea thickness, thin corneas, are also a big risk factor for glaucoma. That was right out of the blue. But there's also some other risk factors. People that are very nearsighted, people who have high blood pressure, but also, and very important, are people who have low blood pressure. Diabetes, people with diabetes, that increases your risk of getting glaucoma by between 20 and 25%. Stroke of the optic nerve, they're fortunately fairly rare. Retinal detachments, migraine headaches. Anybody who's ever had migraine headaches are at increased risk for glaucoma. And that's just because their blood vessels are a little bit different. Cardiovascular disease. People who have very healthy cardiovascular systems are much less at risk of getting damage from glaucoma. Family history. If you have a father with glaucoma, your risk goes up a little bit. If you have a mother with glaucoma, your risk goes up a little bit more. But if you have a brother or sister with glaucoma, your risk goes way up. Long-term steroid use. And what people forget about, this also includes inhaled steroids. So people who are taking steroids for asthma, and they've been taking them for years, that greatly increases the risk. Sleep apnea, that's another big risk they found. So if you need that CPAP, use it. And as mentioned, age gets you for everything. So your probability after age 50 does go up significantly. So why does the pressure go up? This is the front of the eye here. There's the colored part, the iris, and there's the clear dome, the cornea. Well, right down here, there's these little things called ciliary processes, and that's where the fluid is made. So this constantly is producing fluid. It goes out through the little hole there, the pupil, circulates around, and it's got to get out a drain right there. Well, there's a magnification of that drain. And it's just like the drain and goes around the outside of your house. If it starts to get plugged up over time with pigment and debris, now the fluid can't get out to get to these veins to be drained away. So what happens? The pressure inside your eye starts to go up. That is a funny looking optic nerve. So here's one from the side. That's just a picture, but there's all the fibers going out the optic nerve, and they go back to the brain from there. That's a plate called the lamina cribrosa, and that supports all those fibers. If the blood supply to those fibers is reduced, they're going to die. It's like anything else. You cut off the blood supply, or there's mechanical pressure here that's also going to cause damage to those fibers. And when I say this is funny, that's an optic nerve. That empty area in the middle is called a cup. So when you look, that's the only fibers that optic nerve has, is just that little tiny rim around the outside. So that is a very suspicious appearance. So when we look inside, we're looking for something like that. Like I said, when I graduated, people with high pressures had glaucoma. People with low or normal pressures did not have glaucoma. Well, that was wrong. So there's a large group of people called, they have what they call normal tension glaucoma. Their pressures are fine. You would look at that and figure, no, that's not a problem. But we'll often look for, say, middle-aged females, normal pressure readings, but they're fairly thin, cold hands. And they often say, yeah, my blood pressure's a little bit low. And also the whole idea of low cerebral spinal fluid pressure is also starting to come into the mix, although there's no good way of clinically measuring cerebral spinal fluid pressure. I'm sure they'll come out with an instrument one day and charge me $60,000 for it. So that gets us into the whole idea of the blood pressure versus the pressure inside your eye, and that's called ocular perfusion pressure. So it depends on the eye pressure and it depends on your blood pressure. So when they measure your blood pressure on your arm, they'll get a certain number. By the time that pressure gets around to your eye, it's a lot lower. So we have to have enough blood going through your eye to keep those little optic nerve fibers healthy. So if you have an eye pressure of a certain amount and a blood pressure of a certain amount, if that pressure inside your eye is too high or that blood pressure is too low, they will close off. The pressure inside your eye will just squeeze those blood vessels shut. So we want to look at that ratio. So when we see glaucoma patients, people are saying, well, why are you checking my blood pressure? That's what we're looking for. Specifically, we want to know if somebody has low blood pressure because they're at great risk of damage. We have to measure what the pressure is inside the eye. That's a thing called tonometry. And these are some tonometers. You may have seen them before. They're all basically doing the same thing. They're putting a pressure on the eye, seeing what the pressure is coming back. And it'll give a reading of what that pressure is. This is a new one we got. This is called a ocular response analyzer, and it does it a little bit differently. Still puts the pressure on there. But all of the other tonometers have a certain little basic built-in flaw, and they assume the thickness of the cornea. And so they can be wrong when they're taking it. If you've got a very thin cornea, it's going to press that. That cornea is going to give more. It misinterprets that as a low pressure. If you've got a very thick cornea, you press against it, you're going to get a higher reading. This one takes the pressure right at the point where the cornea buckles. And so you got a zero area. So they call that true IOP. Corneal thickness. Remember, thin corneas are a risk factor, so we want to know how thick the cornea is. This thing does it with ultrasound. Digital imaging, also very important. So we want to look at those optic nerves and find out just how big that empty area in the middle is. That's called a cup. And therefore, how much nerve fiber we've got left on the rim. This gives a 3D appearance, so you can tell exactly where it is. Not using that so much anymore. Visual fields. This was a huge step forward in the 1980s. Computer-assisted visual fields. It can go out and plot any area you've lost as far as glaucoma damage. This is a very typical glaucoma damage. That's called an arcuate scotoma. Scotoma just means dead area. The problem with visual fields is, though, in order for it to find anything, you would have to lose at least 50% of your nerve fibers. So by then, the game's half over. So although we still do visual fields, never rely on them for detection. But if you are following damage, it's still useful. Plus, if the college comes in and looks at my records, there'd better be a visual field there once in a while. It's a really boring test, though. Gonioscopy, that's another thing we do. Remember, we were looking into that drain. This little instrument allows you to look directly into the drain. So you want to find out, is there a whole bunch of extra pigment in there? Is there a reason that the flow of fluid may be, or is the angle, the little drain itself, getting very narrow? Blood pressure, as I mentioned, very important. Hysteresis, that's a new measurement, but that's the overall rigidity of the eye. There's a few journal articles coming out on that, but low hysteresis is showing to be a very good indicator of how fast somebody may progress with glaucoma. Glaucoma itself is usually glacially slow in most people, so you've got lots of time to assess what's going on. This is probably the biggest thing to happen in glaucoma ever. This is where you find glaucoma with the visual fields. This is where you can detect glaucoma with OCT. So it can actually measure the little nerve fibers becoming thinner. It'll actually put your nerve fiber thickness into a database and compare you to other people your age and race, because it does vary with race. And then it'll rate it. Say that's obviously that's too thin, that's a dangerous area. And then you also get out into the macula and looks for similar thinning out there. So that is a really good indication. We've got some glaucoma damage there. This one down here looks pretty good around the optic nerve, but we are getting some thinning in the macula there. So this thing will pick up damage years earlier. They say 6-7 years earlier than any other way of determining it. So we tend to rely on it a lot. So there is no cure for glaucoma, but there is management. That's the key. The goal is to stop the disease from progressing. And this involves careful monitoring. The primary treatment for glaucoma is to decrease the pressure within the eye. There's no such thing as a normal pressure. The pressure that you want is the pressure that you've obtained that stops progression from happening. And that's a bit of a trial and error thing. But there's no such thing as 14 is perfect for everybody. You get the pressure down, monitor and see what happens. If it's all okay, then we're good. So to get the pressure down, you primarily do this with eye drops. Probably 90% of the time it's done with eye drops. What these drops do is they either increase the outflow of the fluid, getting the pressure down, or they decrease production of the fluid. Some of them are combinations. So occasionally that doesn't work, and that's why they make glaucoma specialists, but they will actually laser little holes in the drain in there, the ALT. Extreme cases, they will actually put a filtering bleb in so that the fluid inside the eye is directly drained out. You do get a very significant pressure drop by then, but you got to be careful with that, because now the outside environment and the inside of your eye are connected, and the inside of the eye never really sees the outside at all, so it hasn't got very good protection against infection and things like that. The MIGS tube shunt, if they're doing cataract surgery, they'll put a couple of these little shunts in, they'll just poke them in, and that helps drop the pressure. And people who have that done, they can often get, say if they're on 3 medications to lower their eye pressure, they'll be able to get off 1. So it's definitely a help. They seem to change the design of those every year, and they're getting better and better. Some of the earlier ones didn't work that long or what have you, but they constantly make them better. Cannabis, everybody asked me about that. It does lower IOP, but it's just not as effective as other medications. However, they are looking for getting the agent out of the cannabis that does the pressure lowering, and so they may be coming out with that as an eye drop, so it might be fairly effective. Neuroprotectives, that's also helpful. If you can stop those nerve fibers from being as easily damaged, it's also a help. So lowering the pressure is the main thing, but omega-3s, there's a fair inflammatory aspect to glaucoma. Omega-3s are your natural anti-inflammatories. Mirtogenol, that's been looked at. Brimonidine, which was a glaucoma drug, is supposed to have some neuroprotective effects. Sometimes it does, sometimes it doesn't. The literature keeps going back and forth on that. Nicotinamide, which is a form of vitamin B3, is also found to be helpful by reducing dysfunction in the ganglion cells. So it's people in the early stages, it's a good adjunct thing to take. So the management is early detection. The earlier you find it, the better. But you don't have to be too early, because remember, it's very slow changing. You can make absolutely certain that somebody has a progressive condition before you commit them to a lifetime of drops. So especially with the OCT, it can find things so early that you've got lots of time to wait and see what's happening. Careful monitoring. We generally see glaucoma patients about 4 times a year. And compliance is the other big one. Maybe not in Canada as much as in the States. The glaucoma medication tends to be very expensive in the States. One of the ones that just came out here about 2 years ago that we use, I think it's about $30 for a month's worth of medication. That same bottle in the States is $450 US. So compliance can be a bit of a problem. Because I always like to find something in a journal that's good. This is the British Journal of Ophthalmology 2017. So if you have one hot cup of tea a day, you're 74% less likely to develop glaucoma. Now the second thing we were going to get into was age-related macular degeneration. The numbers here are larger. So it is the leading cause of vision loss in people over 40. If you're between the ages of 43 to 54, 8.5% of the people have it. If you're over 75, 36.8% of the people have it. There's approximately 2.1 million people in Canada with AMD. There's 180,000 new cases of dry AMD every year and 17,100 new cases of wet AMD. And I'll explain the difference between the two. So your risk factors, Northern European origin. It's nice to have the blonde hair and the blue eyes, but there's bad stuff comes with that. Actually, anybody can get it now, but the large group is definitely that whole Northern European group. Age, gender, women, somewhat more than men. Family history, definitely a factor. Smoking, diet, we'll get into that a little bit. Excessive sunlight exposure, light-colored irises, high blood pressure, being overweight, and low macular pigment density. And we'll talk about that in a sec too. So what is it? We're going back to our drawing again. There's the optic nerve. The macula is the very center of the back of the eye. And this is a drawing of one, and this is basically what's going on there. We got a pigment layer right down at the bottom. Then we got these little guys here, photoreceptors. They're called cones. And then coming out of that is all the wiring. So that is the nerve fibers. And there's actually about 1,200,000 nerve fibers. Little dip right in the middle of the macula because half the nerve fibers are going that way, half of them are going that way. So that's the exact center of the back of the eye. The other big feature is there's no blood vessels there. And that is good because if there was blood vessels there, that's the most sensitive part of your eye. It would block your vision. But the macula now has to get its blood flow from elsewhere. It's got to get it, and that's why the macula runs into problems later on. That last one was a normal retina. Here is a retina with macular degeneration. We got all these little yellow dots there. Those are called drusen. There was our little photoreceptors. There's our pigment layer, and here these drusen guys are starting to build up underneath the pigment. The whole function of this area, it's got one thing to do. It takes light energy and it turns it into an electrical impulse by a chemical reaction. And that's going on a gazillion times a day. So at some point, anytime there is a chemical reaction, there's waste products given off. And ordinarily they are absorbed by that pigment there and dumped out into the vein system, just flushed away. With enough oxidative stress and so on, the waste stuff doesn't get moved away. So we start getting buildups of discarded proteins and inflammation and so on, and that starts to cause irregularities there. So that's what you see when you're looking in. You see those little yellow dots. They're garbage dumps, basically. That is dry macular degeneration right there. If the distortion and damage becomes extensive enough, now fluids and blood can leak through from below. You're not going to notice vision loss with the dry macular degeneration very much, but you will notice vision loss with this. This whole area is now distorted and compromised. And it can go on to total scarring. That's called geographic atrophy. That's relatively rare these days, but you still run across it. How does a person with macular degeneration see? Well, it starts sort of like this. You lose that central vision. Everything out here is fine. It's right in the middle. Unfortunately, that's the vision you need for driving, reading, and things like that. So the management, when I mentioned macular pigment density, the eye has this built-in little sunglasses inside, and it's a oily layer that sits right in front of the macula, and that's called macular pigment. We can actually measure that and find out what that level is. So even if somebody doesn't have macular degeneration, but they have a family history or whatever, you can check that and you can get that back up just by supplementation. So if you've got low macular pigment density, fix it. It's very easy to do and it's really cheap. Digital imaging, there is an enhanced digital imaging. It allows us to see if you're getting more or less drusen. Used to do that quite a bit, not so much now. Autofluorescence, that's really fascinating, and tissue in trouble will glow white on these things. It's picking up a protein called lipofuscin. Tissue that's sick or dying starts to build up lipofuscin. It would glow a bright white on the FAF image. Tissue that's not functioning would be dark. So you can tell whether the tissue is dead. The optic nerve has no photoreceptors in it, so it's dark. But it's a good old OCT again that has really revolutionized looking at macular degeneration. These are OCT images. That's a normal macula right there. There's the little dip. These are hard drusen starting to build up there. So that's what dry macular degeneration, that's quite a large one, but they come in different sizes and so on. And then this is wet. There is fluid leaked right into that area there. That whole area is damaged and the architecture is gone. Hyperperimetry, also useful at times. You want to tell whether somebody with dry macular degeneration, whether it's becoming wet. This is a fairly sensitive way of picking that up, although you can see it directly with the OCT. So, treatment, the ARID study, that came out, it was about 25 years ago now, and it showed that antioxidants and zinc greatly reduced the progression of macular degeneration. The early ones they had, there was a lot of zinc in it and so on, but a lot of that has been improved over the years. So that is a very good way of managing the macular degeneration. Does it work? Well, there's somebody who was put on it really extensive drusen, and there's a good half of that is gone. So the antioxidants, they do work. However, 2013, Archives of Ophthalmology, they extended the ARID study for another 6 years. They took it out and they found out there's two genetic types of dry macular degeneration. There's the CFH and the ARMS2. Nobody really cared about that before. If you got macular degeneration, doesn't make any difference, but it does. So there's somebody taking a genetic test to find out which type they have. And the reason it makes a difference, so there's zinc. This is an ARMS2 guy here. So there is your progression with zinc. There's the antioxidants, way higher. The CFH guy, he's just the opposite. There's the progression with zinc. There's the progression with the antioxidants. If you got both, and some people have both genetic types, then you're probably fine with the ARIDS formula with the zinc. But it's important to know what kind you have because it really affects the outcome. Omega-3 also, it's important, again, because it's inflammation at the retinal level. You want to reduce that. Omega-3 is your natural anti-inflammatory. This was another one. There was a couple studies done on resveratrol, and they actually, it was a doctor, he was in charge of the Veterans Hospital in Chicago, and he put 21 people on this. They had wet macular degeneration, very advanced. Some of them didn't want to get injections. Some of them they'd given up on the injections, and but he put them on resveratrol, and he reversed 18 of them. I went all the way down to Phoenix to hear his presentation for one day. But I thought that was fascinating. It mimics a calorie-restricted diet. Iron and copper, very bad for maculas. So you want to check your levels. Don't take excessive. You don't want to become anemic, but don't take any more than what you need. And the older you get, the less you need. When we're talking about diet, this is not your good diet. It's a nice looking BLT, but that's not really good for maculas. Remember, we're talking about those macular pigments, and they are lutein and zeaxanthin. That's what forms that little layer in front of your macula. Lutein you get in the leafy green things. Zeaxanthin comes in the orangey things. So that pepper actually should be an orange one. That's the natural way of getting it. So spinach, lots of lutein in it, except in 1955, one thing of spinach would be the equivalent of 27 bowls of spinach today. And that's because they grow multiple crops per year. There's not an awful lot left in the soil as far as nutrients and so on. So either grow it yourself or take the supplements. For the advanced, this is the injections they do called anti-VEGF injections. These people have to get this injection about once a month, but it does seal up those leaks. Unpleasant as that sounds, it's way better than the alternative. So you just don't want to get to that point. So this is your checklist. Pigment density, you want to know what that is. Wear your sunglasses. If it's bright out there, make sure you're wearing the protection. Transitions, that's the lenses that change color. I'm not a huge fan except for people with any kind of macular condition. You want the protection. If there's any UV or blue out there, you want to be wearing protection. The genetic testing, very useful to know. So you're going to take the Macula Plus or First Line of Defense. One of those is without zinc, one of them is with. So you've got to know which one you should be taking. Lutein and zeaxanthin, remember that's in your leafy greens and your orange peppers and stuff like that. Omega-3 because it's anti-inflammatory. Resveratrol. Checking with the OCT, and if there's any suspicion that there's any drusen there at all, you want to have an OCT done. Hyperfields, not so much now. The diet, reducing sugar and metals. So cut down the sugar, cut down the metals, and regular monitoring. And thank you.
Hello, thanks for the presentation. You mentioned that one way to tell if you have AMD is by losing the central vision. Are there other ways to tell if you have a dry or wet AMD or glaucoma?
No, that's the sneaky thing with these things. You can't tell until it's advanced, and you don't want it to get to that. Advanced glaucoma, I've inherited a couple of those patients. You do not want to be there. Basically, you're looking out of this little tube. The whole idea is to catch these things early and look at the risk factors and then do something about it. But yeah, there's just no way that you can tell. Remember the visual fields, you have to lose 50% of the fibers before it'll find it. You got to lose more than that before you notice that you're missing vision from glaucoma.
Thank you very much for a very interesting presentation. I have a couple of questions. I didn't find out the difference, or whether that's important, the difference between wet and dry degeneration. And second question, more personal. I don't like to wear sunglasses, but I'm a sailor and I have white skin and light color eyes. Would you please elaborate a little bit whether, and I don't have degeneration yet, but should I use a protection? Thank you.
Oh yeah, I mean, one of the two highest UV areas where you'd be at the highest risk is either on snow or on water. So yeah, that is a huge risk for that. So out sailing, you definitely want to be wearing the protection. It's all relative, you know. You know what the risk is, you know what the downside is, but you know, it's probably not worth taking the chance. And you saw the difference between the wet and the dry there. The reason they call it wet is because of that fluid that's leaking into the back of the retina, whereas with the dry, there is no fluid leakage. It's just the little drusen guys that are starting to build up. At that stage, most of the time, you don't even have any visual symptoms. It's the wet that you really notice.
Thank you, Dr. McRoberts. Now, will taking a vitamin or a supplement like Costco sells Vitalux, will that stop the progression, or is it just through diet?
Here's the problem. Vitalux is an air-rich formula. The original Vitalux, they had lots of zinc in that, and everybody was getting upset stomachs and everything like that. They have changed it. But depending on the type, the genetic type, you're taking that zinc, you might be making things worse. So Vitalux is probably the right thing to take about 25% of the time. The other 75%, no. The problem is you don't know if you're one of those 25%. And the only way you can find out is doing the genetic testing. But if you're one of the people, somebody has macular degeneration, they got both genetic types, yeah, then Vitalux is fine for them.
I have appreciated looking at the visual presentations of the circles and of the eyes and that sort of thing. I'm a glaucoma patient, and I've lost 75% of the vision in my right eye. And I was interested in what you had to say about one eye sometimes progresses faster than the other, which is my case. I've recently had surgery and had stents put in my right eye and my cataract removed, which has made a huge difference. And I'm scheduled to have my left eye done at the end of this month, have stents put in. So this has all been extremely interesting to me. But what is the best way to monitor my vision for any change, like for a new candidate?
It's not something you can very easily do yourself. Once you have more advanced glaucoma like that, the best way to monitor for change is visual fields. So it doesn't pick up stuff very early, but it's actually quite good at finding out, oh, the visual field loss is greater, it's not under control. So it's not something you can really do at home. But they should be doing that at least twice a year on you as a full visual central field. And then they know they've got it. But yeah, if they get the pressure down with the stents and so on, it's just a matter of keeping what you've got. Very important. And then protect the eye that's doing better. So they know if you tend to change rather rapidly, more so, then really watch out for the other eye, because it's likely going to do the same thing.
So how do we start the process in BC? Do I come to you? Do I need a referral from a physician? Is it covered by the health plan?
You don't need a referral because we're considered primary care. It's partly covered. It's a strange system in BC. It's partly covered by the medical plan, but a lot of the stuff that we do is not. So OCT, no. If we had to wait for the medical plan to pay for it, the instruments would be obsolete by the time that. Yeah, it's partly covered, but then most people have extended, which was also billed directly with that too.
So, Dr. McRoberts, this is part of our Health by Stealth series. I just want to ask you a quick question. Why do you think this topic is important to the series?
Well, these particular ones, I do a lot of dry eye. There's a lot of other things, but the two things that are really make these stands out because people don't know they have them until it's fairly advanced. So whereas the key with this is to catch them early, but there's no symptoms. The patient doesn't know that. So this is the one I like to keep going back to, the glaucoma and the macular degeneration. Cataracts, yeah, people know they're getting cataracts. Dry eye, yeah, people know they're getting that. But the glaucoma and macular degeneration, the glaucoma, especially, that's why the Americans got a turn of phrase for everything. They call it the thief in the night, because most glaucoma damage happens when you're asleep, because when you go to sleep, your blood pressure goes even lower, your eye pressure goes higher, and that's when a lot of this damage occurs. So because people don't know that they have a problem until it's fairly advanced, that's why I think something like this is especially important to get the awareness there.
We all have an interest in our vision. It contributes to our mobility, it contributes to our satisfaction of life, it contributes to a whole lot of our life. And so this has been helpful and I think important to us, to each of us, particularly to me as a spouse of a glaucoma patient. Thank you very much for coming. I have learned a lot listening to you this morning. And thank you very much. I'd like to give you this certificate of appreciation on behalf of the Men's Shed. A box of Squamish chocolate.
Ooh.
For a prize in our community.
Ooh.
Thank you very much.
Well, thank you all very much. Thank you.